Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm speaking to Professor Dame Helen Stokes-Lampard, who's a GP and now the National Chief Medical Officer for New Zealand. Helen took on that post 6 months ago, however many listeners will know her from previous roles as Chair of the Royal College of GPs and Chair of the Academy of Medical Royal Colleges in the UK. In this conversation, Helen explains what prompted her to take such a big step in her career and move to the other side of the world, how the health system in New Zealand compares with the UK, and what it's like working as a frontline GP there, as well as the emotional impact of leaving her practice and her life in the UK. She also offers some practical tips to other GPs taking on leadership roles and those considering moving to work in another country based on her own experiences, and offers her views on the UK government's decision to scrap NHS England, where she was a member of the board before her move overseas. This is a really great conversation. It was really good to talk to her again, and I hope you enjoy this interview. I'm very, very pleased to welcome onto the podcast now Professor Dame Helen Stokes-Lampard. Helen is a GP and is now the National Chief Medical Officer for New Zealand. However, she'll be very well known to many GPs in the UK for numerous leadership roles in general practice in this country. She's a former chair of the Royal College of GPs and a former chair of the Academy of Medical Royal Colleges. And before she left the UK to move to New Zealand, she was chair of the National Academy for Social Prescribing and a board member of NHS England, alongside her roles as a GP in Staffordshire and as a professor at the University of Birmingham. Thank you so much for coming on the podcast today, Helen. It's really good to see you.
Kia ora, Emma. It's lovely to see you again. It's been a long time.
Yeah, so big move since we last spoke. I mean, moving from the UK to New Zealand, that is a big change, isn't it? Was a big move like this always on the cards, or was it part of a wider plan, or was there something specific about this job that particularly attracted you to it?
It was never specifically on the cards. You know, if you'd said to me a few years ago, are you going to be in New Zealand in a few years? I would have said, no. Doing something different was always on the cards at this stage in life. When I was chair of the academy, I remember sort of thinking quite seriously about halfway through, what on earth follows this? It was such a remarkable and life-changing experience. And you think, what do I do next that will be as fulfilling as these roles that I've had, where I can use some of the skills and the experiences and give back and put this stuff to good use? And emerging from the end of that, just looking around, and there were so many interesting opportunities, but nothing seemed to lift the hairs on the back of my arm. Does that make sense? Everything was, yeah, okay, I could do that, or I could give that a go. And so the headhunters reached out to me about this role, and they previously said, look, would you be prepared to go abroad? And I talked about it with my husband, and he was at a point in his career where he was ready for a new opportunity and challenge. He's an engineer, not a medic. And so I'd said yes, but never, ever thinking it would be a permanent job overseas. I thought, perhaps it'll be, a 12-month, 18-month opportunity to go and help establish a new healthcare system or building primary care or doing something interesting and integration-wise. And then suddenly they said, there's this permanent job in New Zealand. They want a new chief medical officer for Health New Zealand, which is the equivalent of the NHS. So it's like the medical director of the health service role would be the nearest NHS parallel, rather than the Chris Whitty government public health type chief medical officer role. They're establishing a new healthcare system called Health New Zealand. They're unifying sort of 20 districts into one, and they've got this amazing vision. And I said, look, send me some information. I'll have a little think. And they sent me a little animation as part of this huge pack of stuff, which summarized the Healthy Futures Act, Peora, which really gave me quite a visceral emotional reaction. And that was my absolute hairs on the back of my arm moment, where I realized this vision of what they were trying to create, which was a healthier society, not just a better healthcare system, a healthy society, was exactly what I've been aspiring to and working towards for at least a decade in the UK. And I called my husband into the study. I remember it clearly. It was a Saturday afternoon. It's about a job. I said, will you just watch this animation? Don't ask me questions, just watch the animation. And we got to the end of the 3 minutes. And so he looked at me and he went, you helped them write this stuff, did you? And that just said it all to me. It was such a natural alignment. I had to find out more. Of course, I had no idea. I never dreamt they'd actually accept me for it. It has been quite a year, because exactly a year ago now, I was out in New Zealand and starting my one-to-one discussions and preliminary parts of the interview.
And so what exactly does your new role involve now? What are your key responsibilities?
The job description that I signed up for and the job I do are rather different. But as anybody in senior leadership knows, you do the job that needs doing at any one time. So nominally, it's to provide senior clinical leadership for doctors. So I'm the chief medical, so doctors. There is a chief nursing officer, works alongside me, a chief allied, scientific and technical, and a range of other clinical leaders. And it's a wonderful team to be part of. They call us the clinical chiefs. There are chief medical officers for each of the hospital districts, a bit like health boards in the developed nations. They are much smaller than ICBs on average because the population of New Zealand is only 5.2 million and there are now 18 districts. So there are 18 chief medical officers, one for each district, and they're my tribe, if you like. And so regularly meeting with and supporting each of them, but also providing guidance and insight into a huge amount of workforce challenges. So a lot of workforce planning that hasn't been done in a nationally consistent or coherent way in the past. It has been done at the 18 district level in the past, which you can imagine has led to an awful lot of unevenness in the distribution of training, lots of challenges there. Trying to take a step back and look at the big picture, the healthcare system. Like every state-funded, taxation-funded healthcare system, there's a huge amount of political input into the priority setting, and it's how we balance what the political priorities at the time are against what we see as the actual frontline need, or where the pressures are. And like every taxation-funded healthcare system in the world post-pandemic, the money is very, very tight. And so how we balance those really tough fiscal challenges with the needs of the people is fun and games. But it's providing that clinical lens. And I always feel as a clinician, we are that much closer to the patients. So we provide that perspective in a very authentic way. And it's very hard to argue with that narrative of the clinician, whereas somebody who's in healthcare management is one further step removed. And despite the fact that nearly all the healthcare management I've ever worked with have been incredible, talented and very caring people, I think you carry huge authenticity and responsibility as a clinician in leadership.
Do you have any real key focus or priorities for the next couple of years that you've got on the top of your list of things to do?
Yes, stabilising the clinical leadership and inspiring the clinical leaders that we have to be the role models for their own people. So I think there's something really important about giving people hope and inspiration. That is, again, a global challenge, not unique to New Zealand, that a lot of clinicians are sort of feeling quite despairing and frustrated at the moment. So giving back their hope is really important. Also working very hard on workforce planning, looking at new models of care, how best to implement them, how to avoid some of the challenges that the UK has gone through, because the UK embraced new models of working and a wider use of allied healthcare professionals across the system, probably embraced that earlier than New Zealand because its workforce challenges hit earlier than New Zealand. And really trying to bring some of the experience to save some of the missteps that the UK made on that journey. But I'm very conscious, you can't say to people, oh, don't do it like that, do it like this. You have to take people on that journey with you and help them work out what's right for themselves in their own context, because there's no denying everything is subtly different here from the UK. And that's an incredible learning experience for me. Very, very interesting.
When you're talking about that there, are you talking about sort of like the rollout, the expansion of things like the additional roles reimbursement scheme in general practice, where like funding has really gone in to support the expansion of the use of allied healthcare professionals over and above GPs, and arguably it should have gone the other way, really? Is that something you're keen to avoid?
There are a lot of parallels with that. So this is hospital and general practice. And interestingly, the gulf between primary and secondary care, I think, is greater out here than in the UK. And it's quite a gulf in the UK, as we both know. If we take the GP bit first, yes, absolutely. There's been a similar scheme out here the last 2 years, but a much smaller scale than the ours scheme was when, we had 5 years of commitment and this incredible rolling program of expansion, the biggest single investment into general practice we'd ever had in the UK. And remember, when that ours scheme was rolled out in the UK, we were desperately short of nurses. We were desperately short of GPs. And we were so grateful for getting pharmacists into our practice, for social prescribing link workers, for getting health coaches, for getting physios, paramedics, all sorts of different types of professionals alongside us to help us. But of course, what happened during those 5 years in the UK is the benefit of the increased training places we had also secured in general practice came through. So that 5 years allowed greater numbers of trainees to complete training and be qualified as GPs. And what didn't happen was the funding to then employ those GPs. That's the bit that went wrong. It wasn't the addition of these extra people who helped us provide a much broader type of care and help GPs focus on what GPs do best. Although it also brought the challenges of learning to lead and support much wider wider ranges of professionals. But the money then required at the end to employ this new cohort, additional cohort of GPs, is what was missing. In New Zealand, I'm trying to nurture the conversation about what do we need for the future? What should the future of care look like? Let's look at the bigger picture. Let's learn from these experiences. There are so many great reports been written by the healthcare think tanks in the UK that we can refer to. There are plenty of theses been written about this situation. Let's see what went well and see what didn't go well in the UK and pick the bits that are applicable to the population here. In hospitals, there has been very uneven uptake of advanced nurse practitioners. So some of the bigger trusts have embraced advanced nurse practitioner role. So you've got nurse endoscopists and so on. You've got advanced nurses in cardiology, but that is absolutely not a uniform thing across the country. And I see great opportunities there for nurses to upskill, and some of them find that incredibly rewarding and satisfying. And other, advanced physiotherapists are another one. There are plenty of other examples across the different clinical groups to work alongside doctors to provide care, combines with enhanced professional satisfaction for the individuals who are upskilling, but also takes some of the acute pressures off the doctor workforce. But it's that thing about allowing doctors to focus on what they're best at without taking away their own satisfaction. And most clinicians who work alongside advanced practitioners find it very worthwhile and positive experience. But there are lessons we can learn.
Taking on this role, moving to New Zealand, has that meant you've had to step away from being a frontline GP? How do you feel about that?
Oh, Emma, it was really interesting to make the decision. Having been a partner in the surgery, it was over 22 years I was a partner in my practice in Lichfield. It was such a wrench to leave. An amazing group of doctors and nurses and the whole team. We were a huge practice. We had over 100 of us working there. We had a great atmosphere. Leaving them and leaving my patients, many of whom I'd known for 22 years, was really emotionally difficult. But I came over here always intending to do some general practice in New Zealand, but not to be a partner again. And in the last 6 weeks or so, I've started back again as a GP. So I did have a 4-month gap away from patients. What was interesting, the first couple of months, I didn't miss it. Now, I was incredibly busy. I was learning so much. But then I started to realize there was something missing in my professional life. And I was working crazy hard. So it certainly wasn't that I was sitting around with nothing to do. But I realized that interaction with patients actually gives you something back as a clinician, as a professional. And so I've been delighted to start. I've actually joined a really small practice, only 3,500 patients, which compared to my practice of 30,000 patients before is a very different way of working. And yet I walk into my consulting room and it just looks so familiar, right? The stethoscope sitting in the right place, the couch is in the right place, the computer's there. It all looks and feels very similar. And then I turn the computer on and the differences come crashing home to me because, okay, it's new software. That was always going to be a thing. Every little bit of the system is subtly different. But it's the payment and co-payment which has been the biggest difference. Money comes into the consulting room, which it never did in the UK. And that has been quite an adjustment for me. I'm getting used to it.
Because people do pay, don't they, to come to see a GP in New Zealand, but it's also sort of co-funded, isn't it, by the government? So how does that all work day to day?
It's absolutely co-payment. It's very similar to the system they have in the Republic of Ireland, state-funded system. The baseline of general practice is core funded by government. However, there is a top-up payment because the co-payment hasn't kept pace. The system couldn't afford it. And what happens is those who are in the greatest financial need pay a minimum fee, which I think is about $19 nowadays. That would be about £9 for an appointment. And there are some areas where the practices are entirely effectively subsidised practices, and you only ever pay that amount. But in the more affluent areas or the less deprived areas, then the practices, the co-payment that's charged varies. And I think the lowest I've heard is about $35, but there are $100 practices in a city, Auckland. So to give you a sense check, the practice where I work, which is in sort of suburban Auckland, reasonably affluent area, but it's quite a long way out of the centre of town. They charge about $69 for an appointment. So that would be about £34 for an appointment. And so what's so interesting is I have to think when I want to call people back for a review, can they afford this? How much can I do in this appointment to save a follow-up appointment? And for me, what I see the greatest impact is on chronic disease management. When people are acutely unwell, people just totally accept it. It's just the way it is here, and people don't begrudge the money. It's just what it costs to get healthcare, right? It's part of your budgeting, and the cost of living generally are less than in the UK. So you pay half the price of your electricity, you pay more for healthcare. Prescriptions are very similar in the way there's a sort of subsidised bit, but there is a lot more use of non-subsidised medication that people are quite comfortable to just pay for. So that's another difference. But it's with chronic disease management where people feel fine and I want them to come back for blood tests. I want to recheck their blood pressure. That's where it's harder to persuade people. It's do I have to, doc? Or can we leave it a bit longer, doc? Subtly different in the way we're working. As it does mean that the consultation rate per person is significantly lower here than in the UK.
Do people have to pay extra for things like tests as well, or is it just all covered in the cost of coming in for an appointment?
It varies. So a lot of tests are included. So, the blood tests that I would require, so somebody's, hypertension, new hypertensive agent, I want to check their kidney function, that blood test would all be covered by the state. That's part of normal care. That's sensible and appropriate. And again, their medication would be, a small prescription fee, or if you have more than a certain amount of medication, free. But if somebody wanted something doing, somebody wanted a physio appointment and they wanted it quickly, then people would just pay. And there's a greater acceptance of paying for things. Interestingly, dental care for adults, there is no state-funded dental care for adults. And of course, I've been one of the lucky ones in the UK. I had a great NHS dentist. I'd been for a checkup just before I came to New Zealand. All was well and good. And then I cracked a tooth a few weeks after arriving here. So I felt the sharp end of needing to pay for a dental crown.
Oh, typical.
I had fantastic service and care. Of course I did. It was brilliant. But it was jolly expensive. And so my running joke at Christmas was, some girls ask for a tiara for Christmas. I just got a crown.
That's a good one, Helen.
Yeah.
Is, the actual business of being a GP, is it quite similar in New Zealand? Is it the same sort of things you see day to day?
Yes, it's, the patients walk in, they have their problems, they have their burdens, they have all that complexity that walks in the consulting room door, and the medicine is the straightforward bit, and it's their lives and everything else that's the complex richness of being a GP. So that bit's very similar, and I came home from my first day in practice, and I had this big grin on my face. My husband said, I haven't seen you come home from general practice smiling that much in a long time. And I just realised I sort of got my mojo back from the clinical bit of it. Being a GP is, of course, it's almost identical. The view out the window may be different. The paperwork and the computers and the processes will be different. But actually that richness and complexity of our clinical lives, that interaction with the human condition and doing our individual bit to help people, as they come through the door is universal.
One of the things I just found really fascinating, and this might really well speak back to that video that you saw when you said the job really spoke to you, is that Health New Zealand's also known by its Maori name, which is Te Watu Ora, which means weaving of wellness. And when I saw that, I thought, I can see why Helen would have liked that. I mean, can you explain a bit more about that name and where it came from and how it applies to you as an organisation?
Absolutely. So it's Te Whatu Ora. So WH is in Maori. Right. Just to be clear, you don't need Maori pronunciation from me. I'm very poor. I'm working on it. Maori words are liberally sprinkled through common parlance all the time. And so you pick up lots of words, find yourself using them more and more. And I'm getting increasingly comfortable with that. And one thing I do want to share before I talk about the weaving of wellness is a lot of Maori custom and practice is embedded into life here in a way that I have loved and embraced. And one of them is the karakia. The karakia is the nearest parallel is like an opening prayer or a blessing to a gathering of any description. So a bit later today, I'll be hosting a meeting and I will start with a karakia, which will be said in Maori. And they are wonderful ways of setting the scene for the gathering we're about to have. And I've actually got the English translation of the one I'm going to use later. And then you finish the meeting with a similar and an appropriate one, which gives you permission to move into your day. So what I'll be saying is, greetings of the day to the people gathered here. Let peace be with us. May we respect each other and what we believe.
That's great.
Isn't that awesome? What a way to set the scene for a meeting where we might be having great differences between us. We might be chewing over very difficult stuff or emotive stuff. Tempers may be raised. But may we respect each other and what we believe is a fantastic scene setter. So coming back to Te Whatu Ora and the weaving of wellness, New Zealand is what they describe themselves as a bicultural society. Obviously, in the UK, we're proud of being multicultural, and certainly living in the Midlands for 25 years, I lived and breathed multiculturalism, and my own practice had this wonderful richness of people from all over the world there. But the bicultural thing is actually legal, set down in law, that back in 1864, when there was a big treaty signed, Treaty of Waitangi, which set the agreement between the Crown of Britain and the native peoples, the Maori. It enshrined in law very strong rights for the Maori people. There were MPs in the first Parliament that were Maori. There were certain land rights and so on. Now, subsequently, there were all sorts of breaches of that, and there was betrayals. But those laws still persist. And so the rights of Maori about self-determination, about land, about knowledge relating to them are a legal concept. So every major, certainly government institution, has a very strong moral and legal obligation to ensure that the culture and traditions are upheld and respected. When they created this new healthcare system, there was an act, the Healthy Futures Act, or Pay Ora, was brought together with very much this feeling of how do we create a better society for all. And weaving is a really important concept in Maori tradition because Maori peoples came originally over from the Pacific Islands. They're water-based cultures. There's an awful lot about people's mode of travel, canoes that they came over, water, but also weaving was how goods and textiles were made. And so weaving is often talked about as a way we do things. We don't smash things together, we weave things together. It's a respectful way to build something and to grow. And there are wonderful principles which include putting cloaks around people, and cloaks bring us together and make us feel safe. Weaving is a respectful way to do things. So the weaving of wellness means that we don't just tell people what to do, we make it better together.
You're a big advocate for social prescribing while you're in the UK. Is social prescribing, is that something that's kind of part of what you're doing there as well in terms of trying to make a healthier society? Does that feature in it?
So social prescribing as a term isn't widely used out in New Zealand, but it is absolutely culturally what they try to do, and particularly with the Maori partnerships that happen. So there are these partnership boards where the sort of Maori cultural and health and wider society are brought together to do what's right for communities. And there's some incredibly creative stuff that happens in these iwi Maori partnership boards. That is not directly my role out here anymore. But of course, as people know my passion for truly holistic healthcare and what I've done in the UK, I'm getting involved in all sorts of fabulous conversations and starting to, I guess, energize and support and lend weight to what others are trying to do. And what it does mean is that when I'm in rooms where interesting conversations are happening about healthcare, I can bring that wider perspective. I try and shine a light on that wider perspective and literally help them to see the bigger picture. At my heart, I'm a controlled politician. Inside there's raging political fire, but I've learned that to be effective, I have to be toned down and controlled. And so to be the best Helen, I have to be a very controlled person. But inside, I want to fix it all. I want all of society to be better. I want everybody to have the chance to live their best possible life. I want us to address what matters to people, not just what's the matter with people. I know that I won't be able to resist as time goes on, getting more involved in that space. But I have so much to do in Health New Zealand right now to help set up some pretty important structural things around clinical leadership. But that has to be my short-term focus, that and the workforce challenges. But there is no doubt that the other stuff will follow because I can't help myself, Emma.
What have been some of the biggest challenges you faced in transitioning to your new role in New Zealand? It's first thing in the morning, you've had to get up at some ungodly hour to do this, and it's last thing at night, like I'm ready for my hot chocolate and going to bed. It must be very hard, just even being on the other side of the world from people that you care about in this country. Has that been the hard thing, or is it just more about the actual job that's been a big transition?
Undoubtedly, the people is the hardest thing, and I would really never underestimate that. And I think as we get older, our relationships deepen. Our sense of familiarity and routine is more and more entrenched. It has been hard. And I think if anybody was reaching out to me asking for advice about whether to do it, what to do it, how to do it, I would sit them down and have a very frank conversation about what you're giving up if you do this sort of thing. I've been so grateful that my husband has just been so supportive. I mean, it was absolutely the right thing for him. Doing it together has actually been helpful, and we don't have children, so we didn't have that complexity of moving children and keeping in touch with people. I mean, I'm such a social person, and I have so many good friends and colleagues, and obviously I'm building wonderful new friendships here, but I want them keeping in touch with a lot of people in the UK. And so, my husband now knows not to criticize me being on my phone early in the morning and late in the night, because that's when I'm WhatsApping with my UK friends. That's when I'm doing quick video calls and and so on. And obviously my family were absolutely devastated. My parents particularly took it very, very hard, and my brother. So that's been really hard to work through because it was never done to hurt anybody. It was done because professionally it was the right thing to do at the right time. I was never going to get another opportunity like this. If I hadn't done this now, 5 years on, people weren't going to be offering me these kind of incredible opportunities. The job itself has been really, really hard. They didn't ask me to come here to do an easy job. They'd found plenty of people to do that, but they wanted somebody with external perspective. I have relished the challenge, but it has been absolutely exhausting. And so any notion that I came out here for a better quality of life has been somewhat laughable because I've been working 14-hour days, Monday to Friday. However, they're very, very respectful of weekends. And it's not often I've had to do significant work at weekends. I mean, I choose to do some work at weekends. That's my choice. But not often they book meetings at the weekend. Whereas I have to say in the UK, it was, I was always seemed to be doing something. I have enjoyed the time with my husband exploring. And there's so much of this amazing country I want to see.
Such a brave thing to do. It's a long, long, long way. But obviously there'll be lots of GPs potentially listening to this. I mean, there's obviously lots of GPs who do make that choice. I mean, medicine is an international career, and there are lots of people who do make that choice to move to Australia or New Zealand or Canada. Those are the kind of top places people go to.
And I must say, if you're thinking about it, you're thinking one of those places, they're definitely New Zealand, right? I have to say that. The recruitment team would kill me if I didn't say that. But no, it is a big commitment to do it. So yeah, I think very long and hard. Interestingly, quite a lot of people get so far through the process and pull out quite late on. I've learned since I'm out here. But it's incredibly multicultural. I mean, the practice I'm working at, my supervisor is a fascinating guy who is actually Norwegian originally, but trained as a GP in Edinburgh. But a huge percentage of healthcare professionals here have been trained overseas. And I want to help New Zealand do more training its own, because there's no doubt we absolutely need more Kiwi.
Is that a big part of what you're trying to do over the next few years, do you think?
Well, it would encourage greater training places for homegrown. Yeah, definitely. There is a tacit understanding that is the right thing to do, but it's a major commitment for a country to invest in training healthcare professionals, in setting up schemes and expanding. We're waiting to hear if there's going. I mean, New Zealand only has 2 medical schools at the moment, which by sort of most international standards would be low for the population. There's talk of whether there'll be a third, and we're expecting a decision imminently. But even then, it would be still nowhere near sufficient to train sufficient doctors to provide enough in the longer term. So yeah, encouraging. But these are political decisions fundamentally. So for me, it's about helping to shine a light on these issues. And it's definitely not just about the doctors, right? It's about the whole breadth of healthcare professionals. But we also know there are so many local people who want to train to do these jobs. It's not that there aren't people wanting to train. There's tons of talent here. And it would be culturally good to see far more Maori and Pacific peoples coming through training as well. I mean, that it will diversify the healthcare workforce in the right way.
It's not all perfect in New Zealand, is it? I mean, I know that you've got doctors striking this week as well. So there are still challenges around issues like that. What's going on with that at the minute, and how does your role fit in with what's happening there?
Yes, I'm deeply saddened by that our senior doctors have got so distressed that they need to strike. In fact, it's 24 hours of full withdrawal of services. So just life-preserving treatment is what will be continuing this week. Ostensibly, the reasons that they're striking are about pay. It's a fairly bold union statement that it's all about the money. And of course, the reality is for senior doctors, it's not all about the money. People are feeling disenfranchised and their voices aren't being heard. They're feeling disempowered. There's been a huge amount of change. And, we know post-pandemic, this is the same in every major healthcare system around the world, that there was a cost to that. And that initial outpouring of euphoria and support for our healthcare professionals dwindled away as the economic challenges on society were manifest. So, yeah, the headline is that it's about the money. But when you talk to doctors, it's not. The money is there, of course it is. And it is a real thing. And, they can plot the graphs and show what their money situation is. But actually, in my experience, doctors don't strike when they feel valued, when they feel empowered, when they feel able to provide good, safe clinical care. Just that money is what sits on the contract. It's difficult and it's a sad day. And so my role in all this, I'm not in the negotiating room. I'm not there in the finance office or with the minister. Where I am is with the people. Where I am is with the chief medical officers. In the short term, obviously keeping our public and people safe. So making sure all the contingency planning. And in fact, as soon as we finish, that's what I'm going to be doing is contingency planning meetings. But actually, I'm also trying to support the chief medical officers so that they in turn can be the leaders that their people need. And I talked earlier about bringing back hope. giving clinicians back their voice, making sure that the decisions we make are the best for the patients we serve. If we keep the patients at the heart of everything we do, we tend to make the best decisions in healthcare.
Just before you left the UK, you were on the board for NHS England. I mean, I know you didn't have that role for a massive amount of time, but I just wanted to ask you what you thought about the government's decision to scrap NHS England and what your view about that was.
I was devastated when I heard the news. I was really upset to hear it because NHS England hasn't been around for that long. It's about 13 years since it had been set up. And over that time, it had done really quite remarkable work. And there were really positive signs of what was going on. There were huge development, so much in the pipeline, and they had gone through the pain and difficulty of enforced mergers, which take years to embed, and they had done it quite remarkably in doing those things. When you think what NHS England achieved during the pandemic, the technology changes that have happened in the UK, the genomics changes, honestly, it's remarkable. And then to dismantle it without major consultation, without the really serious legal and understanding and impact of what it will take. I mean, it's going to take years to dismantle properly, with massive legal implications. None of the work can stop, right? All the work that it was doing has to be done somehow. It's now just going to be done by another entity, which is going to be the Department of Health. I don't mind at all if the decision in the long term was that you don't need a body like that. In the same way, in New Zealand, you could say you don't need a health in New Zealand. You could just have the ministry and you could have the districts, which is what they had before. The problem is that when you do things in haste, you repent at leisure. And this felt to me hasty. So, from across the water, I could give that perspective. And so it left me with a sense of sadness because I can see obviously the personal awful costs on people I care with and have huge respect for, but also the frustration that such good work that was in train is now going to fall by the wayside as the people who are leading it are going to be looking for other jobs and so on. It's an interesting, bold move for government also because it puts the responsibility squarely on the shoulders of ministers, whereas before, by creating the buffer organisation in the middle, you had different types of accountability and governance, and ministers could blame the organisation in the middle if there were problems, and actually ministers lose that completely. They lose their protection. So I think it's going to be really interesting to watch. I just really hope now I know that serious consideration and thought is going into mitigating the transition and making it as painless as possible. And yeah, I'm sure there's a few shoulders. Well, I'm offering my shoulder for people to cry on across the water already.
Part of your role, obviously, on the board was to give that sort of GP perspective. And there's been a recognition that perhaps general practice hasn't been very well represented at that senior level in the past. And as a leader, how important is it to have that GP voice at the top of these sorts of organisations?
It's absolutely vital, and no doubt about it there. And I was so relieved because actually I was involved with the board long before the sort of formal appointment stage. I was sort of helping and informally giving some perspective. And I really felt that I could add value. I didn't want to be the one bleating on saying, don't forget general practice, don't forget general practice. But actually bringing that wider primary care perspective was so important, and it did feel valued and appreciated. Richard Meddings, who's now the former chair, said to me, we absolutely have to replace you with another person who can bring a primary care perspective. It's essential for the board. And over here in New Zealand, what's actually great is there are several senior clinicians in medical leadership who come from a general practice perspective, so that voice is heard. The chief medical officer in the ministry is also a GP clinically. So although most of the clinicians we work alongside are hospitalists, we do manage to get that across, and that I am very grateful for.
You've obviously now got a very, very, very senior leadership role, but you've been quite a high-profile leader for general practice in the UK as well. What would you say the key things you've learned that helped you to be an effective leader?
I think, Emma, it's all about the people. I genuinely care about people. So, when I talk about this stuff, I think you start with yourself. First of all, I think you need to understand yourself pretty well, how you work, what makes you tick, what energizes you, what your weaknesses are, what derails you. For people entering medical leadership, in fact, any senior leadership, making sure you really do understand yourself in quite a deep sense. and then turning that to those immediately around you, understanding and investing in understanding those around you. I'm naturally warm and emotionally intelligent, and I'm a sort of maternal person. But for those who aren't naturally those things, the investment in understanding those around you pays dividends, because when you have greater insight, you'll understand how to get the best out of people, what to do when they're under pressure, how to compensate, and how to build a team of people that aren't all the same. I mean, I've absolutely learned that you should seek out difference and other views and not just stick with what's comfortable and cozy. It's so easy to appoint people like yourself, and I think that's a mistake that's really easy to fall into. And actually, some of the most effective teams I've been in have been comprised of really quite different people who have had different skill sets that complement each other. Now, that doesn't always make for the easiest and most comfortable ride, but it does mean that people see the obstacles and see the challenges and see ways around them in a much more creative way. I mean, I guess the best parallel is if you ever go into one of those escape rooms type situations, do not go in with people who think exactly the same way as you. That way leads to disaster. You want people who think differently. Take somebody young, take somebody creative, take somebody analytical. It's that stuff just scaled up. Life is short. If you cannot get enjoyment out of what you are doing, then you need to take a long, hard look about why you are doing it, because your negativity and unhappiness will manifest on those around you. You're not just being unhappy yourself. You are not being a great leader if you are not able to get at least some degree of satisfaction and pleasure out of what you're doing and project that to those around you.
What advice would you give to younger GPs starting out who are interested in taking on leadership roles in the future? How best can you sort of start developing the skills you need to succeed?
I've not written books about this stuff or anything, and I'm not sure I'm the best example, because my career feels like it's been far more about serendipity than any great plan. But what worked for me was I saw things that were interesting, and I made space in my life to do interesting things. So some things piqued my curiosity. I thought, I'd like to find out a bit more of that, but I'm far too busy. How do I create the time to do that? And so for me, one of the big things I had to learn was to stop doing other things. So learn when to move on from one thing to try something different, because I think as healthcare professionals, we can't fail at being doctors. We can't be bad at being doctors. We have to be really, really good at what we do. But just about everything else we do, we can give ourselves permission to fail. I.e., you have a go at something not knowing if you're going to be good at it or not. And that's quite a culture shift from the clinical way we learn. And so you can miss out on incredible things if you don't give yourself permission to not be great at it. And if you're not great at it, obviously you have to give yourself permission to move on and let somebody else do a better job. So that was very liberating for me, because I like to see, I'm a completer finisher. I like to see things through to the end. And most jobs I've done don't have a logical end. I mean, plenty have been short-term contracts where the end is created for you. But so giving yourself permission to fail. If it looks interesting, have a go and make space for it. If it's not giving you satisfaction and getting something back, then is it the right thing to be doing right now? Because there are so many jobs and roles and things that need doing in medicine. There is space for everybody to do something. It may not be quite what you expected it to be. I never dreamt that I would end up doing the crazy things that I'd done, that I'd be a professor of GP education, that I'd be, leading the Doctors in Health New Zealand, that I'd be setting up social prescribing, but I followed what gave me satisfaction and what I felt passionate about, and the rest just fell into place.
Do you think you'll come back to the UK at some point, or are you in New Zealand for the long haul now?
I honestly don't know, Emma. I mean, everyone keeps asking me that question, and I'm due to come back to the UK in June to visit family and friends and to go to a couple of conferences. And I think that'll be really quite an interesting experience. My mother would desperately love me to say, I'm just doing this for a year and then I'll be back. My husband, I think, is pretty confident that he'd love to stay here forever. He feels very happy. Already he feels that. I just think it's way too soon to say. What I do know is the job I'm doing is a big job. It's not a quick job. And I absolutely want to do my best for it and to see it through and to see things to a better place. So I'm going to be in New Zealand for quite a while yet. So if anybody's listening wants to pay us a visit, we've rented a house with spare bedroom and great views. So, just get in touch. It's lovely to have visitors, although it is a very long way away.
It is, isn't it? It's been brilliant to talk to you, Helen. Best of luck with it all. Thank you so much for coming on the podcast.
It's such a pleasure to be back, Emma. Thank you so much.
Well, that's it for this week. Thanks so much for listening, and thanks again to Helen for taking the time to talk with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources to support you in your day-to-day role on our website at GPonline.com.